Hello students, today we are talking about abnormalities of the placenta and umbilical cord. Word placenta derived from the Latin root meaning a flat cake and was introduced by Aurelius Columbus in 1559. Placenta abnormalities are better understood with knowledge of placenta implantation, development, and anatomy. At term, the typical placenta weight is approximately 500 grams, is round to oval with 22 centimeters in diameter and has a central thickness of 2.5 centimeters. It is composed of placenta disc, extraplacental membrane, and 3-vessel umbilical cord. Placenta actively regulates the passage of substrates necessary for fetal growth and development. The maternal surface is the basal plate, which is divided by clefts into portions termed cotyledons. Those clefts mark the site of internal septa, which extend into the intervillous space. The fetal surface is the chorionic plate into which the umbilical cord inserts, typically in the center. The placenta attaches to the uterine wall and allows metabolic exchange between the fetus and the mother. The placenta has both embryonic or fetal and maternal components. The embryonic portion comes from the outermost embryonic membrane. The maternal portion develops from the decidua basalis of the uterus. The placenta membrane separates the embryonic blood from maternal blood, but is thin enough to allow diffusion and transport of nutrients and waste. Placenta acts as respiratory, excretory, nutritive, protective, and endocrine organ. In addition to placenta's role in transporting molecules between mother and fetus, it is a major endocrine organ. It turns out that the placenta synthesizes a huge and diverse number of hormones and cytokines that have major influence on ovarian, uterine, mammary, and fetal physiology. Now let's talk about abnormalities of the placenta. During pregnancy, the normal placenta increases its thickness at a rate of approximately 1 mm per week. Also not measured as a component of routine sonographic evaluation, this thickness typically does not exceed 40 mm. Placentomegaly defines those thicker than 40 mm and commonly result from striking villous enlargement. These may be secondary to maternal diabetes or severe maternal anemia, or to fetal hydrops or infection caused by syphilis, toxoplasmosis, or cytomegalovirus. Less commonly, villi are enlarged and edematous and fetal parts are present, such as in cases of partial mole or a complete mole that coexist with a normal twin. In some cases, rather than the villous enlargement, placentomegaly may result from collection of blood or fibrin. for example, in intervillous or subchorionic thrombosis and large retroplacental hematomas. On this image, you can see ultrasound image of placenta, which thickness is 8.2 centimeters, which is twice more than normal. Placenta hypoplasia is defined as placental weight below 500 grams. The causes for placenta hypoplasia it's a fetus death and intrauterine fetus growth restriction. Placental hypoplasia usually distinguish between two forms. Primary, it's in fetus genetically disorders, often present in trisomic chromosomal abnormalities, and secondary, circulatory insufficient, infection, and hypertensive disorders. Placenta insufficiency. It's a serious complication of pregnancy. These blood flow disorders is marked by a reduction in the mother's blood supply. When the placenta malfunctions, it's unable to supply adequate oxygen and nutrients to the baby from the mother's bloodstream. Without this vital support, the baby cannot grow. This can lead to low birth weight, premature birth, and birth defects. Now let's talk about abnormal shape or implantation. Bilobed placenta, or placenta bilobate, or placenta duplex, is a placenta with two roughly equal-sized lobes separated by a membrane. It occurs in 2 to 8% of placentas. The umbilical cord may insert in either lobe or filamentous fashion or in between the lobes. While there is no increased risk of fetal anomalies with this abnormality, bilobed placentas can be associated with first trimester bleeding, polyhydramnios, abruption, and retained placenta. A placenta with more than 2 lobes is rare and is termed a multilobate placenta. The accentuate placenta is a condition in which one or more accessory lobes develop in the membrane apart from the main placental body, to which vessels of fetal origin usually connect them. The vessels are supported only by communicating membrane. This condition occurs in 5% of placentas. Advanced maternal age and in vitro fertilization are risk factors for the accentuate placenta. Other factors leading to accentuate placenta include implantation over leiomyomas, in area of previous surgery, in the corner, or over the cervical os. Ultrasound, particularly colored Doppler, can be used to identify this condition. The risk of vasa previa and retained placenta are increased with this condition. Fenestrated placenta, or placenta fenestrata, is a rare condition in which the central portion of the discoid placenta is missing. Rarely, there may be an actual hole in the placenta, but more frequently, the defect involves the villous tissue and the chorionic plate remains intact. At delivery, this finding may cause concern for retained placenta. Circumvallate placenta is an extrachorial annulary shaped placenta with raised edges composed of a double fold of chorion, amnion, degenerated decidua, and fibrin deposits. In this condition, the chorionic plate is smaller than the basal plate, resulting in hematoma retention in the placental margin. Within the ring, the fetal surface has the usual appearance, except that the large vessels terminate abruptly at the margin of the ring. Circumvallate placenta is associated with poor pregnancy outcomes due to increased risk of vaginal bleeding beginning in the first trimester, premature rupture of the membranes, preterm delivery, placental insufficiency, and placental abruption. The diagnosis is difficult to make during pregnancy and is often made on visual inspection of the placenta after delivery. The ring-shaped placenta is an annulary shaped placenta. It can sometimes be a complete ring of placental tissue, but more often tissue atrophy in a portion of the ring result in a horseshoe shape. The incidence is less than 1 in 6,000. The ring-shaped placenta can cause antepartum and postpartum bleeding, as well as fetal growth restriction. Extrachorial placentation, or placenta extrachorialis, is a rare type of placenta. Placenta extrachorialis is a morphological abnormality of the placenta, defined as a condition in which the transition from the membranous to villous chorion does not occur at the placenta edge, but at some variable distance within the circumference of the placenta. Placenta accreta. Placenta accreta is the abnormal adherence of the placenta to the myometrium, associated with partial or complete absence of the decidua basalis and an abnormally or incompletely developed fibrinoid Nitabuch layer. When normally developed, those layers represent the cleavage line allowing a normal third stage of labor. The prevalence of this condition has been increased and now occurs in 1 of 2,500 pregnancies. The incidence of placenta accreta increased in women with previous cesarean delivery, other uterine surgery, advanced maternal age, high gravidity, multiparity, previous curettage, and placenta previa. The highest risk for placenta accreta is in pregnancies with a history of cesarean section and a current placenta previa. There are 3 types of abnormal placenta adherence: placenta accreta, increta, and placenta percreta. Placenta accreta. Placentas villi are attached to the myometrium. Placenta increta is a form of placenta accreta in which the placental villi penetrates the uterine muscle or myometrium, but they do not penetrate the uterine serosa. Placenta increta accounts for approximately 15 to 17% of all placenta accreta cases. Placenta percreta is a form of placenta accreta in which the placental villi penetrates the myometrium to the uterine serosa. Placenta percreta accounts for approximately 5 to 7% of all placenta accreta cases. On this image, you may see placenta accreta when placenta villi attached to the myometrium, placenta increta, in which placenta villi penetrates the uterine muscle but do not penetrate the uterine serosa, and placenta percreta, when the placenta villi penetrates the myometrium and uterine serosa. Ultrasound features suggestive of placenta accreta include deficiency of vascular lacuna, myometrial thinning, and interruption of the bladder line. Grayscale sonography has a sensitivity of 77% to 87% and a specificity of 96 to 98% for placenta accreta. MRI does an appraisable improve the diagnostic accuracy when compared to ultrasonography. An attempt to deliver an adherent placenta can result in hemorrhage, shock, and uterine inversion. Hysterectomy traditionally treated placenta accreta, but uterus-conserving treatments are now commonly used. Degenerative placenta lion. Placenta calcification. Calcium cells may be deposited throughout the placenta, but are most common on the basal plate. Calcification occurs with advanced gestation and is associated with nulliparity, smoking, higher socioeconomic status, and increasing maternal serum calcium levels. Calcification can easily be seen sonographically. Lines of the placenta that are consistent with maternal vascular underperfusion are consistently associated with stillbirth and neonatal mortality. In surviving children, there is a significant association with neurological impairment. Obstructive vascular lion are strongly associated with neonatal morbidity. Ascending uterine infection is also strongly associated with neonatal morbidity. It is recommended that pediatrician assess the result of the histological examination of the placenta, as this may help explain poor neonatal outcomes and may have implications for treatment. Circulatory disturbance. Those are clinically important syndromes, and in most cases the placenta is target organ of maternal disease. Functionally, placenta perfusion disorders can be grouped into those in which there is disrupted maternal blood flow to or within the intervillow space, and those with disturbed fetal blood flow through the villi. Those lesions are frequently identified in the normal mature placenta. Also, they can limit maximal placenta blood flow. Placenta functional reserve prevents harm in most cases. Indeed, some estimate that up to 30% of placenta villi can be lost without untoward fetal effects. If extensive, however, those lesions can profoundly limit fetal growth. Placenta lesions that cause abnormal perfusion are frequently seen grossly or sonographically, where smaller lesions are seen only by microscopic examination. Hemorrhage, edema, placenta vessel thrombosis, and fractions, those are circulatory disturbance. Let's talk separately about maternal blood flow disruption reasons. Subchorionic fibrin deposition, Those are caused by slowing of maternal blood flow within the intervillous space with subsequent fibrin deposition. Blood stasis specifically occurs in the subchorionic area, and lesions that develop are commonly seen as white or yellow firm plaque on the fetal surface. Perivillous fibrin deposition. Maternal blood flow stasis around an individual villus result in fibrin deposition and can lead to diminished villous oxygenation and syncytial trophoblastic necrosis. Within limits, those grossly visible small yellow-white placenta nodules are considered to be normal placental aging. Maternal floor infarction. This extreme variant of perivillous fibrinoid deposition is a dense fibrinoid layer within the placenta basal plate, and it is erroneously termed an infarction. The lesion has a thick, white, firm, corrugate surface that impedes normal maternal blood flow into the intervillous space. Those lesions are associated with miscarriage, fetal growth restriction, preterm delivery, and stillbirth. Those adverse outcomes occasionally recur in subsequent pregnancies. Their etiopathogenesis is not well defined, but some cases are associated with lupus anticoagulation. On this image, you may see perivillous fibrin deposition. Intervillous thrombus. This is a collection of coagulated maternal blood, normally found in the intervillous space, mixed with fetal blood from a break in a villus. Grossly, those round or oval collections vary in size up to several centimeters. They appear red if recent or white-yellow if older, and they develop at any placental depth. Intervillous thrombi are common and typically not associated with adverse fetal sequelae. Because there is potential for a communication between maternal and fetal circulations, they can cause elevated maternal serum alpha-fetoprotein levels. Another reason for maternal blood flow disruption is an infarction and hematoma. Chorionic villi themselves receive oxygen from maternal circulation supplied to the intervillous space. Any uteroplacental disease that diminish or obstruct this supply can result in infarction of individual villas. Those are common lesions in mature placentas and are benign in limited numbers. If they are numerous, however, placental insufficiency can develop. When they are thick, centrally located, and randomly distributed, they may be associated with preeclampsia or lupus anticoagulant. The maternal placental fetal unit can develop a number of hematoma types. Those include retroplacental hematoma between the placenta and its adjacent decidua, marginal hematoma between the chorion and decidua at the placental periphery, known clinically as subchorionic hemorrhage, subchorial thrombosis along the roof of the intervillous space and beneath the chorionic plate, and subamnionic hematoma. Those are of fetal vessel origin and found beneath the amnion but above the chorionic plate. Sonographically, those hematomas may resemble a crescent-shaped fluid collection that is hyperechoic to isoechoic in the first week after hemorrhage, hyperechoic at 1 to 2 weeks, and finally anechoic after 2 weeks. Most subchorionic hematomas visible sonographically are fairly small and of no clinical consequence. Extensive retroplacental, marginal, and subchorial collection have been associated with higher rates of miscarriage, placenta abruption, fetal growth restriction, preterm delivery, and adherent placenta. Now let's talk about fetal blood flow disruption. Fetal thrombotic vasculopathy. Deoxygenate fetal blood flows from the two umbilical arteries into arteries within the chorionic plate that divide and send branches out across the placental surface. Thus, eventually supply individual stem villi, and their thrombosis will obstruct fetal blood flow. Distal to the obstruction, affected portions of the villus become infected and non-functional. Thrombi in limited numbers are normally found in mature placenta, but those may be clinically significant if many villi become infected. Next, it's a subamnionic hematoma. As I told you before, those hematomas lie between the placenta and amnion. They most often are acute events during third stage of labor, when cord traction rupture a vessel near the cord insertion. Chronic layer may be cause fetomaternal hemorrhage or fetal growth restriction. They also may be confused with other placental mass, such as chorioangioma. In most cases, Doppler interrogation will show absence of internal blood flow that permits differentiation of hematoma from other placental mass. On this image, you see subamnionic hematoma. Placenta calcification, calcium salt, are most common on the basal plate and is associated with smoking. Now let's talk about placental tumors. Gestational trophoblastic disease is a pregnancy-related trophoblastic proliferative abnormality. It's a rare variation of pregnancy of unknown etiology. There are two varieties of molar pregnancy. It's an complete mole and incomplete mole. Persistent or malignant disease will develop in approximately 20% of patients with molar pregnancy. The incidence of molar pregnancy vary among different nations and ethnic groups. The highest incidence occurs among Asian women living in Asia, 1 case in 200 pregnancies. The incidence in US is approximately 1 in 1,500 pregnancies, with recurrence rate of 1 to 2%. It is associated with low dietary carotene consumption and vitamin E deficiency. Partial moles are associated with history of infertility and spontaneous abortion. The genetic constitution of the two types of molar pregnancy are different. Chorioangioma. Those benign tumors have components similar to blood vessels and stroma of the chorionic villus, also called chorangioma. Those placental tumors have an incidence of approximately 1%. In some cases, maternal serum alpha-fetoprotein levels may be elevated with those tumors. Chorioangioma sonographic appearance has well circumscribed, rounded, predominantly hypoechoic lesion near the chorionic surface and protruding into the amniotic cavity. Increased blood flow by color Doppler helps to distinguish those lesions from other placenta masses such as hematoma, partial hydatidiform mole, teratoma, or leiomyoma. Small chorioangiomas are usually asymptomatic. Large tumors, typically those measuring more than 5 cm, may be associated with significant arteriovenous shunting within the placenta that can cause fetal anemia and hydrops. Hemorrhage, preterm delivery, amniotic fluid abnormalities, and fetal growth restriction may also complicate large tumors. Because of this, some have treated large tumors by interdicting excessive blood flow using vessel occlusion or ablation. Tumors metastatic to the placenta. Malignant tumors rarely metastasize to the placenta. Of those that do, melanomas, leukemias, and lymphomas, and breast cancer are the most common. Tumor cells are usually confined with the intervillous space. As a result, metastasis of the fetus is uncommon, but is most often seen with melanoma. Another reason for circulatory disturbance is an placenta abruption or normal implanted placenta preterm separation and placenta previa. Abruption is the premature separation of normally implanted placenta before delivery of the fetus, with blood collecting between the placenta and the uterus. It is one of the most important causes of antepartum hemorrhage. The other one is placenta previa, accounting for 30% of all cases of antepartum hemorrhage. It is an important cause of perinatal mortality. It is estimated to occur in 6.5 pregnancies per 1,000 births. Its effect on the fetus depends on its severity and the gestational age at which it occurs. There are two main forms: concealed, where hemorrhage is confined within the uterine cavity and is the most severe form. The amount of blood lost is easily underestimated. Revealed, where blood drains through the cervix, usually with incomplete placental detachment and fewer associated problems. There are recognized factors that increase risk of premature separation of the normally implanted placenta. Those include hypertension due to preeclampsia, gestational hypertension, or chronic hypertension. Previous abruption carries the highest risk of abruption in current pregnancy. Multiply pregnancy. Trauma. Threatened miscarriage early in current pregnancy. Multiparity. Previous cesarean section. Smoking and cocaine abuse. Thrombophilia. Intrauterine infection and polyhydramnios. Fetal hypoxia due to an abruption will lead to heart rate abnormalities seen on cardiotocograph. Depending on the degree of detachment and the amount of blood loss, the mother may be collapsed and the fetus hypoxic or already dead. Placenta previa occurs when the placenta implants totally or partially in the lower segment of the uterus rather than in the fundus. In complete previa, the internal os is completely covered by the placenta. In partial previa, a portion of the internal os is covered by the placenta. In marginal previa, the edge of the placenta extends to the edge of the cervical os. A low-lying placenta will commonly be defined as within 2 cm of the cervical os without covering any portion of it. Those conditions occur in approximately 1 in 200 to 250 pregnancies, and risk factors include prior cesarean delivery, previous abortion, prior intrauterine surgery, smoking, multifetal gestation, increasing parity, and maternal age. A woman with a history of placenta previa is 12 times more likely to have placenta previa in a subsequent pregnancy. Ultrasound screening programs during first and early second trimester pregnancy now include placenta localization. Transvaginal ultrasound can also make a diagnosis. Delivery should be a cesarean section as dilatation of cervix causes separation of the placenta, leading to bleeding from the open vessels. Vaginal delivery is an option for those with low-lying placenta, as the bleeding morbidity has proven to be limited. Placental vessel thrombosis. Most descriptions of placental disease have concentrated on structural abnormalities that affect the maternal vascular supply line. Only recently has attention been focused on lesions affecting the fetal vascular supply. 4 major pathological processes have been described that affect large fetal placental vessels. It's an fetal thrombotic vasculopathy, velitis of unknown origin with obliterative fetal vasculopathy, chorioamnionitis with severe fetal vasculitis, and meconium-associated vascular necrosis. All of those may contribute to perinatal brain injury occurring well before birth. Severe fetal placenta vascular lesions are especially highly correlated with neurological impairment and cerebral palsy. And now let's discuss abnormalities of the membranes. There are few abnormalities of the fetal membrane that may be associated with adverse outcomes. Meconium staining. Fetal passage of meconium before or during labor is common, with cited incidence that range from 12 to 20%. Importantly, staining of the amnion can be obvious within 1 to 3 hours, but its passage cannot be timed or dated accurately. Chorioamnionitis. Normal genital tract flora can colonize and infect the membrane, umbilicum cord, and eventually the fetus. Bacteria most commonly ascend after prolonged membrane rupture and during labor to cause infection. Organisms initially infect the chorion and adjacent decidua in the area overlying the internal os. Subsequently, progression leads to full thickness involvement of the membranes, chorioamnionitis. Organism may then spread along the chorioamnionic surface to colonize and replicate in amniotic fluid. Fetal infection may result from hematogenous spread if the mother has bacteremia, but more likely is from aspiration, swallowing, or other direct contact with infected amniotic fluid. Most commonly, there is a microscopic or acute chorioamnionitis, which is caused by a wide variety of microorganisms. This is frequently cited as a possible explanation for many otherwise unexplained cases of ruptured membrane, preterm labor, or other cases which is unexplained. In some cases, gross infection is characterized by membrane clouding and is sometimes accompanied by a foul odor that depends on bacterial species. Other membrane abnormalities. Amnion nodosum. The condition of amnion nodosum is characterized by numerous small, light tan nodules on the amnion overlying the chorionic plate. Those may be scraped off the fetal surface and contain deposits of fetal squamous and fibrin that reflect prolonged and severe oligohydramnios. Amnionic band. There are at least 2 band-like structures that can be formed by the fetal membranes. Amnionic band sequence is an anatomic fetal disruption sequence caused by bands of amnion that interrupt fetal structure and impair their growth and development. In contrast, an amnionic sheet is formed by normal amniochorion draped over a pre-existing uterine synechia. Generally, those sheets pose little fetal risk, also slightly higher rates of preterm membrane rupture and placental abruption. The most widely held theory concerning amniotic band etiology is that early rupture of the amnion results in adherence of part of the fetus to the underlying sticky chorion. Amnionic bands commonly involve the extremities to cause limb reduction defects and more subtle deformations. They may also affect other fetal structures, such as the cranium, causing encephalocele. And now we discuss abnormalities of the umbilical cord. The umbilical cord provides communication between the placenta and the fetus and allows gas and nutrient exchange. The normal diameter of the umbilical cord is less than 2 cm, The umbilical cord grows until the end of the second trimester to a length of 50 to 70 cm. Cord abnormalities related to morphology, coiling, placenta insertion, number of vessels, diameter, and blood flow pattern can contribute to perinatal complications. Most umbilical cords are 50 to 70 cm long, and very few measure less than 32 and more than 100 cm. Cord length is influenced positively by both amniotic fluid volume and fetal mobility. The normal umbilical cord contains 2 arteries and 1 vein. The umbilical vein carries oxygenated blood from the placenta and connects with the left portal vein in the fetal liver. The umbilical arteries carry deoxygenated blood from the fetus to the placenta. Violation of blood circulation in the vessels of the umbilical cord cause acute fetal anemia, often fatal, asphyxia of fetus passing or ending with death, intrauterine growth restriction due to insufficient blood supply. Short umbilical cord. It's the cord which length is less than 40 cm. Short cords may be associated with fetal growth restriction, congenital malformations, intrapartum distress, and a twofold risk of death. When pulling a short umbilical cord during labor, it may cause preterm placenta separation or umbilical cord rupture. Long cord. It's a cord in which length is more than 70 cm. Excessively long cords are more likely to be linked with cord enlargement or prolapse and with fetal anomalies, acidemia, and demise. Loops. It's the case when the cord frequently becomes coiled around portion of the fetus, usually neck. A normal length cord may become relatively short because of multiply looping around the baby's neck. Umbilical cord knots. A knot that forms in the baby's umbilical cord. True knots normally form between 9 and 12 weeks gestation, because that is the period when the amniotic fluid level is very high. There is also evidence that true knots form during labor. Umbilical cord knots occur in about 1 in every 100 pregnancies. Babies with long cords and those who are small fetuses are at greater risk for developing true knots. The most common sign of a cord knot is decreased fetal activity after 37 weeks. If the knot occurs during labor, a fetal monitor will detect an abnormal heart rate. Umbilical cord prolapse is where the umbilical cord descends through the cervix with the presenting part of the fetus. It affects 0.1 to 0.6 of birth. The incidence of mortality is high. This is largely because cord prolapse occurs more frequently in preterm births, who are often breech and who may also have other congenital defects. The main risk factors for cord prolapse include breech presentation, unstable lie, artificial rupture of membrane, polyhydramnios, and prematurity. Cord coiling. Umbilical cord coiling provides cord strength and protection against cord compression, twisting, stretching, and other forces that could interrupt cord blood flow. Umbilical cord coiling is evaluated postnatally by calculating the umbilicum coiling index, which defined as the number of cord spirals completed per centimeter of cord length. An abnormal umbilicum coiling index is defined as either a hypercoiled cord or hypercoiled cord. Hypercoiled cord is associated with an increased rate of intrauterine growth restriction, fetal demise, intrapartum fetal heart rate deceleration, fetal distress at delivery, and karyotype abnormalities. A hypercoiled cord is associated with an increased risk of fetal intrauterine growth restriction, intrapartum fetal cardiac deceleration, vascular thrombosis, and cord stenosis. This is how we count the umbilicum coiling index. It's the number of cord spirals completed per centimeter of cord length. Umbilical vessel abnormalities. Occasionally, the usual arrangement of two thick-walled arteries and one thin larger umbilicum vein is altered. The most common aberration is that of a single umbilical artery with a cited incidence of 0.63% in live-born neonates, 1.92% with perinatal deaths, and 3% in twins. The cord vessel number is a component of the standard prenatal ultrasound examination. Fetus with major malformations frequently have a single umbilicum artery. Several maternal risk factors have been associated with fetal single umbilical cord, including advanced maternal age, white ethnicity, multiparity, smoking, diabetes, hypertension, preeclampsia, maternal drug use, and epilepsy. The prevalence of single umbilicum artery is 3 to 7 times higher in multiply gestation than in singleton pregnancy. Associated congenital structural abnormalities of the cardiovascular, gastrointestinal, central nervous, and genitourinary system are seen in 33% of fetuses with single umbilical artery. There is a 10% risk of associated chromosomal defects, especially trisomies 13, 18, and 21. Single umbilicum artery is seen in 40% of fetuses with trisomy 18. A fetus with single umbilical artery is at higher risk of being in intrauterine growth restriction. Full vessel cord. Full vessel umbilicum cord anomaly commonly seen are 2 umbilicum arteries and 2 umbilicum veins, but it may be 3 umbilicum arteries and 1 umbilicum veins. These may be associated with multiply congenital malformations, including congenital heart disease, genitourinary malformations, skeletal malformations, central nervous system malformation, cleft lip, and fetal hydrops. Usually, single umbilicum vein is present at birth and is derived from primitive left umbilicum vein. Normally, the right umbilicum vein gets obliterated by 7 weeks of gestation. Rarely, persistence of caudal part of right umbilicum vein can lead to presence of 2 umbilicum veins. Incidence of persistence of right umbilicum vein has been seen in 0.2 and 0.4% cases. Persistent right umbilicum vein without any additional malformations has a good prognosis. Routine examination of the umbilical cord postnatally for the number of blood vessels should be done, and in case of multiple vessel cord, detailed examination and investigation to rule out any associated congenital malformation should be done. The cord normally inserts centrally into the placental disc, but eccentric, marginal, or filamentous insertions are variants. The eccentric and marginal are clinically important in that the cord or its vessels may be torn during labor and delivery. Marginal cord insertion is seen in 5 to 7% of pregnancies, and it's also referred to as battledore placenta. Marginal cord insertion is best diagnosed using Doppler ultrasound, which will demonstrate cord insertion near the margin of the placenta within 2 cm of the placental edge. Marginal cord insertion can develop into filamentous cord insertion as the pregnancy progresses. This change may result from atrophy of the placental tissue at the cord insertion site due to a relatively poor regional blood supply. Marginal cord insertion has a high prevalence in multiply gestation and can lead to potentially unequal shearing of the placenta tissue and resultant growth discordance. In single-tone pregnancies, marginal cord insertion is not associated with an increased risk of fetal intrauterine growth restriction or preterm delivery. Many placental and umbilicum cord lesions can be identified grossly or sonographically, but many abnormalities require histopathological examination. That lecture was dedicated to description of some abnormalities of the placenta and the umbilicum cord. Thank you for your attention.